Thank you. It's my pleasure to be here today. I have to say I put this presentation together last week or maybe 1 or 2 weeks ago. And as I was sitting here this morning and listening to all the ideas, I was thinking, oh yeah, I should have talked about that and I should have talked about that. But we do have a very limited amount of time to speak. So I'm just happy to be with all of you today. So as we talk about, if I can get this to work. As we talk about Minnesota's program, it was actually brought into legislature in 2008, and at that time, it was named, the legislature chose to name the program Healthcare Home to really acknowledge the shift from a purely medical model of healthcare and a focus on linking that primary care with preventative, community, and services for those that are medically unstable across the care continuum. So this was a lot of foresight on the part of the legislature and on the part of parents who had experienced a pediatric medical home in Minnesota in the late 1990s, early 2000s. So at this time, our staff has really doubled in size. Since about a year ago, we are now our current staff that are doing the work for Healthcare Home and for the State Innovation Model testing grant for accountable communities for health and behavioral health homes. So we're all working together to use Healthcare Home as the foundation for all of these projects to move care more into the community and to look at more collaborative partnerships. 3 areas of our program that we were asked to identify that really are strategic are the certification process, it's our quality improvement process, and learning through our learning collaboratives. So we see our dynamic components as multi-stakeholder involvement, which has involved patients and external partners from the very beginning of the program. These partners include payers, they include advocacy groups, they include other healthcare partners, and people representing primary care clinics throughout the state of Minnesota. It was an expectation of this law that patients would be involved in every aspect of development, and to this day they're involved at the program level as well as the community or at the clinic level. At the clinic level, patients through the certification process are required to be on the advisory board and somehow related to the quality improvement that is performed by that clinic. Each clinic is to have a quality improvement process, and it is to be informed by patients. Another aspect of patient participation in our program is that 25% of our legislative advisory committee contains patients, as well as other community stakeholders. And a little side note to that is that we also contract with some patients from the state of Minnesota to actually act as site visit evaluators with our Healthcare Home site visit team. So we view our program as a relation-based program, and that can be recognized in several different ways. First of all, it's the care coordinator, developing that relationship with the patient. It's the physician actually identifying their panel of patients and actually helping that patient to understand that it really provides a better basis of care to choose a primary care provider. An aspect of our program that's probably a little bit different from other programs is that we do site visit verification. So at certification, we actually have a team that goes out depending on the size of the clinic. It will depend on the size of the team. But the team includes one of our regional nurse planners, as well as a consumer or a patient that has contracted with our agency, as well as probably a community nurse or community health professional. That would be the minimum team that goes out to work with clinics to verify that the processes and are put in place to redesign primary care. One of the other issues with our standards is that we sometimes struggle, as I know our clinics in Minnesota struggle with, is that our standards are not very prescriptive. We require an access policy. We require a care plan for certain identified patients with complex needs, but we're not prescriptive on how that looks. And we really work with our clinic partners to have them take some time to identify the patients that they serve and how they think best they should serve those patients. So it's not a perfect science by any means if they say that it's the complex people who tier at level 3 and 4 with our payment methodology system that receive care plans. But it's up to that clinic to really decide and to analyze and use that data to see if that's the correct process for their clinic. So another part of innovation and flexibility with our certification processes is that we're not prescriptive on who should be the care coordinator. We're starting to see that clinics actually start out with certain levels of licensure, possibly a registered nurse as their care coordinator, but as they get further into the process, we're starting to see that they're adding possibly a social worker as a care coordinator, possibly a community health worker, or they're looking at other members of the healthcare team, such as a medical assistant or others that they have on staff to really utilize their resources well. Some of our small solo practice clinics in rural Minnesota do not have all the resources that they'd like to have for hiring care coordinators. So they're really starting to assess their population and identifying what they feel would be best for that population. I just wanted to share with you too one recent occurrence within the last 2 weeks. We know that healthcare home regional nurse planners will be an integral part of certification for behavioral health homes, and that should start possibly about January 1, 2016, or at least by July of next year. And we already know that there's a group of first implementers for that program. Many of them are healthcare homes, our clinics that have been certified as healthcare homes. But about 2 weeks ago, the very first mental health center in Minnesota was certified as a healthcare home. So it's your behavioral health providers who realized that the population that they were working with and with forward thinking are also going to be seeking certification for behavioral health homes too as a Medicaid service. So they took some time and went through a lot of challenges actually to put into the access that's needed for a healthcare home, as well as hiring a primary care provider, which is a nurse practitioner in their case. So that is a milestone for us in Minnesota. Very quickly, I don't know how my minutes are going, 2 minutes left. I just wanted to share with you that this is the evaluation results that are up on our website. There's certainly more detail. This is our 3rd year evaluation, and currently we are undergoing our 5-year evaluation. And so by the beginning of next year, we should have more results about our program. But this truly lends us to think more about what we want to measure about our program. What do we want to know about the impact of our program? What do we want to know about provider and healthcare home team satisfaction once the care redesign has been put into place? So this is raising a lot of questions in our mind, and as you all know, this is not work that is static. This is work that is ever evolving. So just to let you know that currently one of our certified healthcare homes, which is Hennepin County Medical Center through Hennepin Health, has just recently completing a study that they're doing about serving a highly vulnerable population. I don't have those results for you today. I wish I did. But they're talking about integrating social service data into their care coordination process. They're looking at the shared mental model of the teams and at what outcome mechanisms may be best to use for this population. So we're waiting for that, and I thought perhaps you might want to think about accessing that soon too. Other work is also being done at an academic level on, on the context and the function of a healthcare home, and so we're looking forward to hearing that too. So some of the opportunities that we have experienced in Minnesota is that we have 53% of our clinics certified, which is 384 last I looked, but it's right around that number. And some of the feedback that we're really getting from some of our clinics, keeping in mind that we have solo practices, we have safety net clinics, and we have very large organizations also, that sharing and the exchange of data, which is probably no surprise to anyone, can be a challenge at times. And just to share information in regards to the patients that they care for and about transitions from the ER, from the hospital to things like that can certainly be a challenge, and to share some of that data. Improved capabilities for data analysis as well as timely data for analysis. So we have varying levels of ability to do some of that data. And if you look at some of the rural clinics and the small rural clinics, they don't have the extra staff to really be working on it. They're working at full capacity to care for the population that they serve. And another comment that we received recently is alignment of reporting requirements. And that came from a larger system in Minnesota who is participating in many, many different initiatives, and some of the reporting requirements get to be similar, but just a little bit different, which causes them to decide which initiatives they may want to do versus maybe certify the rest of their healthcare home clinics. So it's all about resources, and it's all about deciding what you're going to use those resources for. And last but not least, I wanted to share this. This is maybe not your typical high complex story, but this is from a clinic, and this was at our site visit. And this clinic is a federally qualified health center. Consider that most of their visits, their higher volume of visits, are for behavioral health rather than physical health. At the site visit meeting, there was 5 patient representatives there, and most of them had their interpreter with them. And so they face quite a challenge at this clinic. They do a great job, and they've made great progress with healthcare home certification. But this, in this clinic, I wanted to just stress that they have healthcare care coordination for those that are homeless. They have healthcare care coordination for some of their pediatric patients who have children and youth with special health needs. They have some for their OB patients, because many of them are at high risk. And they also have a social worker care coordinator for their behavioral health side in their clinic. And then they also identified this mother, who is a mother of 5, and was seeking all of the care for herself and for her 5 children in the ER. So therefore, the child was not caught up on well child check, excuse me, immunizations, and just general care, preventive care. So they're also focusing on preventive care. And now that they've worked with the mom, they have these children up to date on their immunizations. They're doing some of their well checks, and hopefully mom is seeking care through her relationship with her care coordinator. Thank you.
Thank you.